Hello and welcome to the Behavior Support Orientation video. The goal of this session is to help with capacity building and knowledge exchange. This video will be an overview of all behavior support services across the Toronto Central region. Behavior Support Ontario, otherwise known as BSO, includes partnerships with Baycrest, Home and Community Care Support Services, Alzheimer's Society Toronto, Woodgreen and COS, UHN, and LOFT. BSO is a provincial funded program that originated in 2010. The goal of BSO is to recognize that all behavior has meaning and that responsive behaviors are often a form of communication of an unmet need. The mission for BSO is to build and maintain capacity for safe and effective management of responsive behaviors, and also to address system leadership and coordination to wrap services around the person with dementia and/or responsive behaviors and their family to improve patient and family experience. The target population is older adults with behaviors associated with complex and challenging mental health, addictions, dementia, or other neurological disorders in the community sector, nursing home or long-term care, and hospital settings and their caregivers. Professionals serving people with dementia, such as private companions, PSWs, registered clinicians, care coordinators, primary care, staff working in long-term care, acute care, or in the community, are supported with the BSO. BSO looks at three pillars to address: system coordination, so looking at coordinated cross-agency, cross-sectoral collaboration and partnerships based on clearly defined roles and processes to facilitate seamless care. Interdisciplinary service delivery, which looks at outreach and support across the service continuum to ensure equitable and timely access to the right provider for the right service. And lastly, knowledgeable care team and capacity building, strengthening capacity of current and future professionals through education and focused training to transfer new knowledge and best practice skills for continuous quality improvement. For today's session, we'll go through all the various BSO funded services. As you can see here, there are various supports in the hospital and acute care sector, long-term care and community, behavior inpatient specialized units. We have an education consortium and our BSO coordinating office. The goal of today's session is to cover each service that is listed here in further detail to give you a better appreciation of how to access the services, what those services look like, and the expectations going forward.
The Behavior Support Outreach team consists of clinician leaders, registered nurses, behavior support specialists, personal support workers, a nurse practitioner, a research coordinator, a behavioral support outreach nurse educator, an addiction specialist, clinical navigators, and administrative assistants. The goals of the Behavioral Support Outreach team are to provide case-based consultation, behavior-based dementia care, and to model and teach strategies to assist in the non-pharmacological management of responsive behaviors in long-term care residents and community dwelling clients. To be eligible for BSOT, clients must be 65 years and older. Their primary concern should be responsive behaviors. They need to be medically stable and reside in the Toronto Central region. BSOT does not accept clients with Huntington's disease or a primary diagnosis of acquired brain injury. They also don't include clients with acute changes in behavior. On the Behavior Support Outreach team is a clinician leader who is the team lead for their subregion. All clinicians, including the clinician leader, registered nurses, and behavior support specialists, work in the community and long-term care sectors to complete behavior assessments, create individualized care plans, and offer transitional support. The nurse practitioner addresses medical contributors to responsive behaviors and works in collaboration with other care providers and physicians. The personal support workers work in both community and long-term care sectors. The PSW works on the following three tasks: behavioral observation, coaching and modeling of behavioral strategies, and transitional support. The wait time for the community is approximately 55 days or less. What to expect from BSOT collaboration. All referrals are confirmed once received by the BSO Coordinating Office. The Coordinating Office will contact the referral source for community and acute care cases for triage and intake. The long-term care referrals will go through intake only. Files will be prioritized based on the outcome of triage. Once BSOT clinicians have capacity to open a file, the referral source will be notified. A typical length of stay is between 8 and 12 weeks. Both virtual and in-person services can be offered. There is an expectation of an active partnership with the referral source and circle of care. BSOT works closely with the client's family members, their caregivers, the POA, or the substitute decision maker.
Next, we'll take a look at the BSO Coordinating Office. The administrative assistants at the BSO Coordinating Office are here to support you. The administrative assistants support the BSO core curriculum education, which includes PIECES, gentle persuasive approach, dementiability, supporting older adults living with mental illness, You First, and BSO Foundations. It's important to note that these courses are for not-for-profit organizations and for staff who are supporting seniors with responsive behaviors caused by dementia or cognitive decline living in long-term care or community within the Legacy Lynn Toronto Central catchment. PIECES is for registered staff only, and You First is the equivalent of PIECES for personal support workers. We also support with the organization of BSO conferences and events, as well as the registration and triage of all BSO referrals received. The clinical navigators at the coordinating office are also here to support you and your clients. Their role is to coordinate BSO services to ensure that the appropriate services and supports are being referred to. They review referrals and support referral sources in making connections across sectors to ensure that appropriate referrals are filled out and that transitions and communication is optimized between teams. The clinical navigators also help to facilitate the development and sharing of resources. They act as a clinical expert and provide clinical knowledge and skills. They are also responsible for triage and intake for BSOT referrals and referrals to the virtual behavioral medicine program. They manage escalations to the VBM program or to the complex case resolution table and support inquiries to the BSO hotline. They ensure collaboration and establish connections to BSO across Ontario. The BSO Coordinating Office can be reached by email at behavioralsupport@baycrest.org. We can also be reached by phone at 416-785-2500 extension 2005 or toll free at 1-844-785-2500. We can be reached 7 days a week from 8:30 a.m. to 4:30 p.m.
The BSO lead is an extension of the BSO program that is embedded in the long-term care homes. The BSO lead is responsible for strengthening the home's ability to coordinate care for clients with responsive behaviors. They lead the behavioral support resource team and oversee the behavioral support care pathway, guiding the team to success. With a focus on a time-limited caseload, the BSO lead receives internal referrals, conducts assessments, engages in care planning, coaching, and ensures the seamless implementation of care plans. Additionally, they facilitate referrals to external resources, lead behavioral support rounds, and actively contribute to the coordination of integrated care across specialty psychogeriatric resources. Their expertise is crucial in ensuring the sustainability of care plans implemented by mobile teams and for fostering a comprehensive approach to behavioral support within the organization. The BSOT resource team operates in collaboration with Woodgreen and the Alzheimer's Society of Toronto to ensure older adults and their caregivers are receiving the support that they need. These services are only accessible by the BSOT team and require an internal referral from one of the outreach staff. The urgent behavioral specialist is housed at Woodgreen and provides assistance to the BSOT team for urgent cases in the community and will escalate the connection to crisis services for clients with a higher need of support. The Alzheimer's Society BSO caregiver specialists are licensed social workers that support the caregivers of people experiencing responsive behaviors due to dementia, mental health, or other neurological disorders. The primary focus of this role is on providing essential assistance to caregivers within the Toronto Central region who are grappling with high caregiver burnout and stress. The BSO caregiver specialists also offer dedicated support through the admission and transition process into long-term care, ensuring a smooth and empathetic journey. They also play a key role in strengthening the working relationships between caregivers and the long-term care home facility staff by fostering an environment of collaboration and understanding to enhance the overall caregiving experience. The BSOT nurse educator role centers around facilitating the BSO core curriculum education for service providers specializing in dementia care. This includes supporting the coordination of the education consortium and establishing criteria for accessing funded BSO core curriculum education. Eligibility includes not-for-profit organizations and public sector clinicians who specialize in caring for seniors with dementia and/or mental health conditions, whether in community settings or long-term care homes. The nurse educator also extends support to acute care clinicians, ensuring eligibility for funded BSO education if their roles involve working with patients in the community or long-term care sector, such as ambulatory or outreach teams.
BSO now also houses an addiction specialist role. This role functions by providing supports to long-term care and for the transition into long-term care for seniors with substance use disorder, with or without a diagnosis of dementia. The role supports seniors living with addiction to alcohol, opiates, cannabis, nicotine, benzodiazepines, and other drugs. This role will also support care teams and caregivers by creating and providing transitional care plans specific to addiction management on a focus of cessation or harm reduction to better support and ensure safe transitions into long-term care or while already living within long-term care environment. There is also opportunity for occasional consultation to the LHINs outside of the TC LHIN legacy borders. This service includes consultation on cases where long-term care homes might be considering declining an application secondary to a client's addiction issues. Our addiction specialist clinician is available via the BSO coordinating office, and individual contact is possible Monday to Friday. Now let's review a case scenario of how BSO can support a transition into long-term care. Here is Mr. WM. WM is a new transition into long-term care from the CAMH centralized access to seniors specialty bed after a 3-month stay. He is having difficulty transitioning back into his new long-term care unit. The long-term care BSOT was referred to due to Mr. WM's exhibiting verbal responsive behaviors such as threatening and screaming at staff, physical responsive behaviors including hitting, following and blocking staff, and this has escalated into 4 cold whites post his initial transition. To provide background, the reason Mr. WM was admitted into the CAS bed was secondary to a noted increase in these previously listed behaviors. Prior to that, the GMOT, Geriatric Mental Health Outreach Team, was involved with this client long-standing due to a comorbidity of developmental delay and dementia. Post the BSOT assessment of the client at his current presentation, using pieces and observation periods, it was determined that the client's main triggers for behavioral outburst were understimulation, frustration focused around not being able to access activities or items that he wished, such as smoke breaks, time with friends, and limited ability to go outside, and lastly, a deep-seated fear of dying alone, like his father had. Now let's review the interventions provided to address the behaviors and triggers we've described. In order to aid Mr. WM in being effective in his ability to communicate his wants and needs to his care team, BSOT recommended that he be provided with additional time and space to articulate these feelings at his own pace. It was also advised that staff allow him more autonomy by actively involving him during care so as to establish rapport and build a trusting relationship with them. Resident was also engaged in meaningful recreational activities, such as water painting, which he greatly enjoyed, wherein staff would provide him with a few paintings at a time and allow him to pick these himself. This led to storytelling and reminiscent therapy, as client would discuss his past as relating to the picture. Thirdly, if he did refuse an activity, staff took time to attempt to discover the emotional cause behind this refusal, such as fear or anxiety, and would validate his concerns. Often, he expressed anxiety around isolation, so staff worked with him to show that he wasn't alone. And finally, Mr. WM was positioned in the open spaces for activities to allow him to be engaged with other residents and staff and receive the care he needed in the time he needed it. And there was success. This was measured and demonstrated by the following outcomes. There were no more code whites after BSOT involvement. The resident is now more engaged with meaningful activities such as drawing, painting, watching fish videos, and aquariums. Staff expressed gratitude and were receptive around the uptake and implementation of the recommendations, and Mr. WM remained at the long-term care with no new need to return to an acute care setting. Now let's look at a community case and meet Mrs. W. BSOT received a referral for this client from an RN who was providing support to her while she lived within a retirement home. At this time, the referral highlighted the following responsive behaviors: agitation, delusion, hoarding, wandering, physical and verbal responsive behaviors, which included kicking, pushing, scratching, and cursing, most notably during resistance to care. And the client also was expressing death wishes, such as, "I want to die, I feel sick." In terms of background, this client was a 92-year-old female with suspected dementia. She also had osteoporosis, stress-induced incontinence, reoccurring UTIs, and a history of constipation, as well as a bilateral hearing impairment. In order to better understand the source of these behaviors, BSOT completed an assessment using the BSO Support Assessment Document, the Cohen-Mansfield Agitation Inventory, the PAIN-AD, and both ABC and DOS tracking. These assessments resulted in the following factors being identified as contributing factors towards the behavioral presentation: unmanaged pain, constipation and the recurring UTIs, short-term memory loss, issues around privacy, sensitivity to noise and being very sensitive to feeling wet, and that the behaviors were most frequent during transitions and during interactions with male staff. After the assessment period was completed, a care plan was created and the following strategies provided. Firstly, a consultation with the general practitioner or GP to better manage pain and constipation. Using an understanding of the client's preferences to inform care approach, and one of the things that was highlighted was how well she did with bubbly personalities and a focus on smiling and laughing with her. Next, allowing and encouraging client to take an active role during personal care, such as giving her the toothbrush or giving her a washcloth. And also giving simple step-by-step verbal directions during care, and following that up with, when needed, physical cueing. The use of a shower cap during care also helped her be more comfortable during washing. Minimizing her exposure and support that is provided to her by a male staff had positive effects, and providing client with specific music support via an iPod provided by the Alzheimer's Society seemed to help her keep calm during transitions. Specifically around toileting, we advise that the double voiding method be used to help with urinary incontinence. There was also the request to schedule more frequent UTI screens so that we could catch those UTIs that were going under the radar, and the use of a log for her to sign at every toileting to provide Mrs. W with a concrete memory cue of the last time she had used the bathroom, in instances where she had become perseverative in her desire to access the washroom multiple times in a day. Again, there were successful outcomes, quite favorable. Mrs. W continued to be supported by the retirement home on the memory floor unit with no need to be transitioned off. Her behaviors became less frequent, they were much easier to redirect, and now were manageable by staff. Neither the family nor the care team felt it necessary to transition this client to long-term care, and as such, she was able to remain in her home and age in place.
The Complex Case Resolution Table, also known as CCRT, is a service provided by the BSO Coordinating Office in the Toronto Central Region. This is a means to escalate and support cases where clients are experiencing a responsive behavior that was not successfully resolved with current local behavior support and specialized services involved. The service brings together specialists, relevant resources, and the client care team to mutually discuss the client's needs and develop a care plan to address them. Client information during the CCRT is kept anonymous. This can be accessed through the BSO Coordinating Office and hotline. It is available to community, acute care, post-acute care, long-term care within Toronto Central Region. Eligibility criteria is the age of 65 plus, with some exceptions for under 65 with geriatric presentation or early onset dementia, and that the client is medically stable. Previous involvement of behavior support services is required.
The Virtual Behavioral Medicine Program is a collaborative partnership between the Toronto Central Behavioral Support for Seniors Program, the Baycrest Sam and Ida Ross Memory Clinic, and the Specialized Dementia Unit at UHN's Toronto Rehab Institute. The VBM program team of specialists include a behavioral neurologist, geriatric psychiatrists, registered nurses and nurse practitioners, pharmacists, social workers, neuropsychologists, behavioral support clinician leaders, and clinical navigators. The program provides quick access to short-term specialized virtual behavioral medicine consultations and management of challenging dementia-related responsive behaviors. It works as a supplement to existing behavioral supports where additional consultation is required to prevent unnecessary hospitalization. For clients in any sector, a referral is required to access the service, and it must be signed by a nurse practitioner or physician. To be eligible for the VBM program, the client must be over the age of 65, have a formal diagnosis of dementia but are otherwise medically stable, have a primary concern for risk of harm to self or others due to severe responsive behaviors, and must have trialed behavioral support services prior to the referral. Exceptions to these criteria may be considered with further information on the history and presentation, but this may be made at the discretion of the VBM program team and clinical navigators.
Centralized access to senior specialty beds, or CAS. The centralized access process to senior specialty hospital beds is a single entry point for providing access to geriatric mental health beds at Baycrest, CAMH, and Toronto Rehab Institute. The CAS units provide stabilization for escalating behaviors that are not manageable in an applicant's current location. Applications are for admission to one of 4 units: Baycrest Hospital Behavioral Neurology Unit, Baycrest Hospital Inpatient Psychiatry Unit, Toronto Rehab Institute Specialized Dementia Unit, and CAMH Geriatric Admission Unit. The admission criteria are as follows: adults aged 55 and older who are medically stable and diagnosed with dementia and associated behavioral symptoms, including those with additional diagnoses of acquired brain injury or traumatic brain injury, Huntington's disease, developmental disability, and other mental health issues. Baycrest Transitional Behavior Support Unit, or TBSU. Transitional high support specialized care in the long-term care sector for individuals whose responsive behaviors have become unmanageable in their current setting. There are private rooms, enhanced staffing. They develop behavior care plans and help stabilize behaviors. They facilitate discharge and transitions to receiving destinations. The estimated length of stay is 120 days. The admission criteria are as follows: one must be medically stable. They must be eligible for long-term care placement. They have a primary diagnosis of progressive dementia with behaviors that could not be managed in their current environment. Available community and/or hospital-based specialized psychogeriatric resources have been trialed and evaluated to be inappropriate or unsuccessful. Behavioral pharmacological review and reconciliation of medications has been completed. For information about the Transitional Behavior Support Unit, you can contact the TBSU social worker or email them. They are located at the Baycrest Apothec Center in the Jewish Home for the Aged at 35060 Bathurst Street.
Next, we'll take a look at the acute care sector. Toronto Central Home and Community Care Support Services provides support through the BSO Emergency Department program. Their team is comprised of nurse practitioners and clinical nurse specialists. Within 3 to 5 business days, their team will assist with behavioral assessment and treatment plans for discharged emergency department patients. Assessments include a medication reconciliation, and if there is no primary care or the patient is poorly connected to primary care, the nurse practitioner will assume that role on a short-term basis. They work in collaboration with all other healthcare providers involved with the patient. Let's look at some of the eligibility criteria for the BSOT ED program. Clients must be 55 years or older, with the exception for younger ages based on geriatric presentation. They must have a suspected or confirmed diagnosis of dementia. They would have to be recently discharged from a Toronto Central Emergency Department, be medically and psychiatrically stable upon discharge, and they must reside in the Toronto Central Region community. An exclusion criteria would be if the primary concern is severe persistent mental illness and/or substance abuse. The UHN Behavior Support Specialist and the LOFT Behavior Support Resource Team help to support hospital sites in Toronto, which also include reactivation care centers, transitional care centers, and reintegration units. Both teams assist those who are currently admitted to an acute or post-acute facility within the geographic boundaries of Toronto Central. They would see those demonstrating complex and challenging behaviors that may result in a rejection to long-term care or barriers to discharge. These would also be clients who are ALC or at risk of becoming ALC. They must be medically stable and free of delirium, and there must be consent to services. The UHN team supports older adults with exceptions made for individuals under 40 years of age with geriatric presentations. They see those with dementia, cognitive impairment, mental illness, mood disorders, problematic substance use, developmental or intellectual disability, and those with mental health symptoms secondary to organic conditions. Our LOFT team assesses those who are 55 years and older with a case-by-case consideration made for younger individuals with geriatric presentation. They work with clients who have dementia or other neurological conditions, mental health diagnoses, and addictions. How our BSO clinicians can help you? Our clinicians can help to create behavioral care plans that are tailored and client-centered. They can help to identify triggers and provide recommendation strategies and interventions which incorporate non-pharmacological approaches. They will work in collaboration with family and caregivers, community supports, BSO partners, and interprofessional teams. They assist in capacity building for teams and caregivers by providing education, coaching, and modeling. They also help to support transitions. They provide hands-on support from acute to long-term care and transitional care units. They will also aid in the completion of the Behavioral Assessment Tool, or the BAT, and also provide discharge planning recommendations. Our referral form can be found on the Toronto Central BSO website or by making contact with our coordinating office. Our team will confirm receipt of referral within 48 hours via email. When possible, please include with your referral any recent medical administrative records, admission notes, and consultation notes.
In order to ensure that we provide a service which is streamlined and efficient, here are some tips to help you get ready when you're preparing to send in your BSOT referral. Please keep in mind to include information regarding other dementia or mental health support teams who might be involved in this client's file. This can include physicians, LOFT services, COS, Alzheimer's Society, GMOT, or more. This ensures that the support efforts are not duplicated and allows teams to better collaborate around client care. Ensure to attach all relevant reports to the referral, and this can include hospital notes, consults from rehab or specialists, or a client's medication list. Remember also that BSOT works in close partnership with our referral sources and will be reaching out to you to collaborate around care when providing service to our population. All BSOT services and the teams reviewed here with you today can be accessed via the referral form, which will be displayed in one of our slides. This can be accessed online and from the website on the slide, the Behavioural Supports Ontario website. Thank you so much.
Thank you for watching the Behavioral Support Orientation video. If you have any questions, please feel free to contact the BSO Coordinating Office via email at behavioralsupport@baycrest.org or at either of the phone numbers listed here.